GI Disorders, Part 1, the therapeutic management. Acute GI hemorrhage has a mortality rate of about 10%. That's gone up. It had been 7%. There's a box on page 846 that lists the possible causes, and a figure on 848 that shows a concept map that looks at the whole picture of GI hemorrhage, symptoms, cause, and the results, the care that we give also. This GI hemorrhage, acute GI hemorrhage, will result in hypovolemic shock and initiation of the shock response. If it's untreated, it can go into multiple organ dysfunction syndrome. And the symptoms depend upon the percentage of the blood that's lost. And there's a box on 846 that talks about the symptoms. But you can lose up to 15% of your blood and still have very minimal symptoms. Your heart rate will be less than 100. Your capillary refill time will be fine. Your urinary output will be fine. All those are normal. The only thing different is that your patient will be a little bit apprehensive and may have some orthostatic hypotension. When you start to lose between 15 to 30%, now your heart rate goes up above 100. The capillary refill time starts to get sluggish. You're going to have a decrease in pulse pressure, tachypnea, and a decrease in urinary output, 25 to 30 milliliters an hour. Blood pressure will still be fine. The heart is able to compensate. So your blood pressure is still okay. But when you start to lose between 30 to 40%, now your heart rate's up above 120. You're very hypotensive. Your skin is cool and pale. You're confused, hyperventilating, and your urinary output's down to 5 to 15 milliliters an hour. When you've lost over 40% of your blood volume, your heart rate's 140, you're extremely hypotensive, you probably have to use a Doppler in order to get that blood pressure, you're confused, lethargic, and you practically have no urinary output whatsoever. There are different types of GI bleed. Peptic ulcer disease accounts for about 21% of upper GI bleeds. We have some normal protective mechanisms to assist us. The mucus protects the mucosa. The epithelial cells secrete bicarbonate. We have tight junctions that protect against acid incursion into that stomach. And the mucosal pH is about 6, even when the luminal or the stomach pH is down around 1.5. The usual cause of peptic ulcer disease is H. pylori and the use of NSAIDs. Now, H. pylori lives there. It thrives in an acid environment, does fine that way. Stress will cause it to become much more active. So stress does have a small play in this, but it's not the big play it used to have. Prostaglandins and nitric oxide also stimulate epithelial cells to secrete mucus and bicarb and inhibit acid production and secretion. Your stress erosive related syndrome or stress ulcer, hemorrhagic gastritis, causes about 15% of your upper GI bleeds. This is usually limited to the stomach. It's due to an increase in acid production and a decrease in mucosal blood flow, which causes a decrease in your mucosal protection and ischemia. Risk factors are burns, trauma, shock, acute CNS disease, like a stroke, being in ICU. 75 to 100% of the patients in ICU have this in some way or another within the first 24 hours. And if the patient hemorrhages, there's a 30 to 80% mortality. Now, the mortality goes up with the more that's wrong with the patient. Esophageal varices are due to portal hypertension secondary to cirrhosis. There'll be a rise in your portal venous pressure that diverts blood to the veins of the esophagus, the spleen, the intestines, and the stomach. And this occurs because damage to the liver's sinusoids causes resistance to blood flow. So you'll have symptoms of spider veins on the abdomen, splenomegaly, a paralytic ileus, nausea, and more. If the patient hemorrhages, you have a 40 to 70% mortality. About 30% will bleed, with 50% stopping spontaneously. Mallory-Weiss tear is a syndrome of massive bleeding after a tear in the mucous membranes at the junction of the esophagus and the stomach. It's due to protracted vomiting. It's most common in alcoholics and pyloric obstruction. And after it's repaired, the prognosis is excellent. And I don't remember seeing this anywhere in the new edition. It was in the older edition, and I think it's something that's valid to look at. So I left it in here. Assessment of a GI bleed. You need to assess the amount of blood loss. Make a guesstimate. Your key markers are hematemesis, which is bleeding above the duodenal-jejunum junction. It will be coffee ground if it's exposed to gastric secretions. Hematochezia, which is bright red blood in the stool. It shows a lower GI bleed, and it causes an increase in peristalsis and diarrhea. Sometimes it causes such diarrhea that it'll drip off the end of the bed. And melena. Now, melena is the black, dark stool that occurs, and it can take up to 7 days to clear after the bleeding has stopped. This is usually from an upper GI bleed, and the blood turns black as it travels out through the GI system. With a GI bleed, it may take up to 72 hours for the H&H to drop because plasma and blood are lost together, and so it'll look artificially okay. This is diagnosed by endoscopy and a bleeding scan. Remember, the bleeding scan is only effective if they're actively bleeding. Nursing diagnoses are found on page 849 and patient education on 850. But your goals of medical management are to stabilize the patient, fluid resuscitation, control or stop the bleeding, diagnostic exams to discover the cause, and prevention of further problems. And on 850, you'll find a box that talks about the collaborative management of an acute GI bleed. But this is some of the things they talk about. Using medications to prevent the problem, such as antacids, histamine blockers, proton pump inhibitors, and cytoprotective agents. Keep in mind, your proton pump inhibitors should be only used short term, less than 6 weeks. And they prevent all gastric acid production and thereby increase the risk for infection. That's why H2 blockers are probably better, but they're not being used quite as often. With the Carafate, you're going to form a slurry if you have to put it down in NG2 because it comes as a tablet. So you'll have to crush it and put it in a liquid, and pharmacy usually does that for you. So you can instill that by the NG2. You need to stabilize the patient, and you do that by administering fluids, crystalloids or colloids, such as blood or blood products. CVP or a PA catheter can be done to assess hydration status. Supplemental oxygen, make sure they're well oxygenated. A large bore NG tube for gastric lavage. And remember, gastric lavage is done to control the bleed or to prepare the patient for a test because you can't look at anything in the stomach if it's covered with blood. It's also done to help obtain an accurate diagnosis. We no longer use iced saline or iced fluids because that can lead to ischemia of the gut. And so if the physician orders that, you don't do it. And there is research to back you up. If the patient is at risk for aspiration, put them on a ventilator. And they definitely need a Foley because you need an accurate INO. To control the bleed, your peptic ulcer, treatment options are thermal ablation. This will use heat to cauterize the bleed. You could also do it. You do that by way of an endoscopy. You can give endoscopic medications. You'll find them on page 804. They talk about hypertonic saline, epinephrine, dehydrated alcohol to cause localized vasoconstriction of the blood vessel. Vasopressin is less effective for duodenal lesions due to the dual blood supply of the duodenum. But intra-arterial vasopressin can be used. Intra-arterial embolization agents such as gel foam, stainless steel coils, platinum microcoils, or polyvinyl alcohol particles to cause a clot at the site where they're bleeding to prevent the bleed from going any further. Stress-related erosive syndrome or stress ulcer uses intra-arterial vasopressin and embolization. Endoscopic therapies are of very little benefit with the stress-related syndrome because of the diffuse nature of the disease. Esophageal varices, you'll use IV medications to decrease the portal venous pressure and slow the bleed by constricting the splenic arteriolar bed. You may use IV vasopressin, IV somatostatin, or IV octreotide. Sclerotherapy or endoscopic injection therapy also works. Now, sclerotherapy is when you inject a sclerosing agent around the varices that causes an inflammatory reaction that reduces vasoconstriction and thrombus formation. An endoscopic variceal band is a latex band that's placed around the varices, similar to a tourniquet. It creates an obstruction and stops the bleed. And the esophagogastric balloon tamponade applies direct vessel pressure to the vessels while decompressing the stomach. This is considered a temporary procedure until you figure out what's causing the problem and stop that. Transjugular intrahepatic portosystemic shunting, or TIPS, forms a channel between the systemic and portal venous systems to redirect blood flow. And there's a picture of this on page 849 and a better one on page 866. Surgical interventions for GI bleed. For peptic ulcer disease, they'll do a vagotomy, which severs the vagus nerve. That will decrease acid formation, but it also decreases motility. So in order to make sure everything still works, they have to do a pyloroplasty, and this provides for gastric emptying. For the stress syndrome, total gastrectomy, if the bleeding is generalized, that will connect the esophagus to the jejunum. Or they can oversew the ulcer if the bleeding is localized, so that will ligate the bleed and close the ulcer. Varices, they can do 3 kinds of shunts, and these shunts are all decompression procedures. They move the blood away from the liver and the portal system, and there are pictures of them on page 849. The portal caval shunt is from the portal vein to the inferior vena cava. The mesocaval shunt is from the mesenteric artery to the inferior vena cava, and the splenorenal shunt is from the spleen to the renal artery. Nursing care of a GI bleed. You want to check that gastric pH every 2 hours, and you can do that with litmus paper. And you want to keep that around 3.5 to 4.5. Room temperature, lavage with normal saline water, iced or cold fluids decrease oxygen to the vital organs and prolong the bleeding time and pro time, so you do not use iced or refrigerated saline to do that, or saline or water. It doesn't have to be sterile. Your stomach is not sterile. Major complication is gastric perforation, and symptoms of that are sudden severe generalized abdominal pain, rigidity, rebound tenderness, fever, tachycardia, an increase in white count, even with fluid replacement. And your interventions are administering fluid volume replacement, control the bleeding, and watch for those complications. And educate your patient. Nursing diagnoses are found on page 849. Pancreatitis, the severe is an acute inflammation, and it produces exocrine and endocrine alterations of function. Now, remember, exocrine means it's through a duct. Endocrine means it's a group of cells secreting into the blood of lymph circulation a hormone that has an effect on the tissues in another part of the body. 80% of all cases of pancreatitis are due to biliary disease and alcoholism. And they estimate the severity by using Ransom's criteria. That's in a box on page 851. If you have 5 to 6 factors, you have 40% mortality. If you have 7, it's 100% mortality. The 2 most common causes, I said, are biliary disease or gallstones and alcoholism. Alcoholism, as I said, is the most common. But there's a list on page 851 for the complete list. Pathophysiology, you have trypsin being secreted, causing autodigestion, and that autodigestion is due to inactive digesting enzymes becoming prematurely activated within the pancreas due to an obstruction or damage to the pancreatic duct system, infection, ischemia, or problems with the acinar cells of the pancreas. This will cause an increase in capillary permeability, which results in edema, hypotension, as the fluid leaks into the interstitium. And you'll have hemorrhage that is due to the elastase destroying the elastic fibers of the blood vessels and the ducts. and that will lead to pancreatic and adipose tissue necrosis due to that lipase. 80% of all patients who have pancreatitis will stop with a hemorrhage. 20% will proceed to tissue necrosis. When you assess acute pancreatitis, now many of these patients don't even end up in the ICU, but these are the most severe cases. And they'll have a box on page 851 for your signs and symptoms. You'll have abdominal pain, nausea, vomiting, tachycardia, fever, diaphoresis, hypotension, tachypnea. On your physical exam, you'll have hypoactive bowel sounds, guarding, distension, tympany, Cullen's sign, remember that's blue around the umbilicus, and Gray Turner sign, that's your blue color of the flank. Tympany, I said that already. Possibly a cyst or an abscess may be palpable. Your labs, there's a table in 852 that talks about it. Your patient will be in metabolic acidosis. They'll have an elevated amylase and lipase. Your lipase is considered a more accurate marker for your pancreatitis than the amylase, but both will be quite elevated. Your white count will be elevated. Your blood sugar will be elevated because you're not producing enough insulin. Bilirubin and protime will be affected. You'll have a decrease in your calcium and your albumin. Symptoms can be mild to severe. It'll be like a twisting knife-like sensation that radiates to the low back. Depending upon the degree of fluid loss, they may even have symptoms of hypovolemic shock. Diagnosis and treatment, you'll have an ultrasound of the abdomen, a CT scan of the abdomen. Now your ultrasound checks for biliary stones, and your CT scan with contrast to differentiate between edematous and necrotizing. The CT scan is your gold standard. It's the best test to be done. Medical treatment for the goals is to maintain an adequate circulating blood volume. To do this, they'll give IV crystalloids and colloids, have the patient on intake and output. And in severe cases, they'll put in a pulmonary artery catheter. They want adequate nutrition, so they may receive TPN, electrolytes to correct the decreased calcium, potassium, magnesium, or the elevated blood sugar. And it may actually be okay to do gastric or jejunal feedings if they're not critically ill, and enteral feedings are always better for your patient. To correct the metabolic alterations, you're going to metabolic acidosis, you'll want to administer oxygen. And you want to prevent complications. There's a box on 853 that talks about them. Shock because of third spacing. It'll be hypovolemic because it's third spaced. Acute lung injury, ARDS, acute respiratory distress syndrome, acute respiratory failure, all due to that inflammatory and immune reaction. GI hemorrhage due to the stress ulcers and the varices. Local complications, infection. And there's a box on page 854 that talks about the signs and the symptoms. You want to treat this with an antibiotic and or surgery if there's necrosis present. A pseudocyst due to obstruction of the main pancreatic duct. This must be drained or it will rupture. If it ruptures, it causes peritonitis. Peritonitis erodes the blood vessels, resulting in hemorrhage. If it's infected, you'll have abscess formation or obstruction. And nursing care, you want to decrease the pancreatic stimulation to slow the autodigestion, so you have them on bed rest. Keep them NPO until the amylase is normal and pain-free. Put an NG tube in if there's fear of aspiration. You could, you want to continue comfort measures like the knee-chest position and relaxation techniques are better. All opioids are linked to spasms of the sphincter of Oddi. So at one time they were only prescribing meperidine because they felt morphine did this more. Research shows it causes just the same amount. So you can go ahead and use the morphine to control their pain. You want to observe for complications. They're on box on 853. And you need to teach these patients about diet modification, maybe using supplemental pancreatic enzymes, diabetes, and stopping drinking. And you'll find all these in a box on page 856. Nursing diagnoses are on page 853, and collaborative management is on 854. And this is the end of part 1. I'll talk with you in a moment in part 2.